Hi, everyone. Good afternoon. Thank you so much for joining us today for our age-friendly geriatrics teleecho series. Today's session is going to be focusing on diabetes health equity for older adults. And our agenda today is just to go ahead and do some welcome introductions, any announcements that we have, moving on into our didactic, and then some closing and reminders. Make sure you stay until the end if you'd like to know what our future sessions are going to be, and also to fill out the CME and evaluation forms. You are all muted upon arrival, so if you do have any questions, you could just hold off until we're ready for questions or put them in the chat and we'd be happy to answer them. As you all know, we are CME accredited, and our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. Our target audience is you all and primary care providers, and we're so happy to have you all here today. Today's session is accredited for 1 CME credit. If you do attend, you will receive a certificate in the coming weeks as long as you fill out the CME form. So thank you so much for doing that. Our series is a part of our HRSA Geriatric Workforce Enhancement Grant at UCI, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. So as we always do, we like to do some quick introductions. I know we have about 30 online at the moment. So if you can just go ahead and put your name, your role, your site, your location, we always really like to see where everybody's joining us from. And that also helps us with attendance as well and CME certifications. But while you do that and put that in the chat, we'll go ahead and have our hub team introduce themselves. Dr. Siegel's not here today, but I'll go ahead and introduce myself. I'm Nika Seville. I'm the project manager for our Geriatric Workforce Enhancement Program here at UCI in Orange County, California. And I'll go ahead and have PA Valerie George introduce herself.
Hi, I'm Valerie George. I'm a physician assistant. I work at Senior Health Center at UCI and outpatient geriatrics. Welcome today.
Thank you, Val. And Dr. Pereira.
Hi, everyone. Welcome. I'm Manisha Pereira. I'm a geriatrician here at UCI. I work in Orange, the Senior Health Center. Welcome.
Thank you, Dr. Pereira. And it looks like we have some people joining us from San Bernardino County, Monterey Park, Marin Community Clinic, Meals on Wheels, San Francisco, San Joaquin Valley. Again, thank you all so much for joining us today. And if you're just joining, please be sure to introduce yourself in the chat. Well, I have the privilege of introducing Dr. Heather Schickedans. She is going to be presenting on diabetes health equity in older adults today. Dr. Schickedans is a family physician and geriatrician practicing in the Los Angeles County Department of Health Services Safety Net. She completed her geriatric fellowship at UCSF, her family medicine residency at UCSF, and she provides direct and supervising care for marginalized persons of all ages and in all settings. And as a faculty educator at UCLA medical students, residents, and fellows, Dr. Schickedans provides supervision and teaching that promotes team-based care to address the social drivers of health. And in her role as chair, she oversees and helps develop and support faculty and staff in the numerous clinical communities settings and programs and scholarly projects whose focus is to promote health equity and racial justice. Thank you to Dr. Schickedans for joining us today. I'm going to stop sharing my screen so she can share hers and we can get it started.
Thank you so much, Nika, and thank you everyone who's joined. I'm just thrilled to see so many different people across the state and beyond, as well as all the different team members. I see nursing, social work, all different parts of our healthcare team. So thank you for joining. I hope to make this session as interactive as possible. And as Nika said, if you don't mind, please put your comments and questions in the chat for now, and then we're going to definitely have time at the end to go ahead and talk about those. I think I might be sharing the wrong screen. Which screen can you see?
I see the presenter view right now.
Ah, okay. Swap. Okay. It's all good?
Not yet.
Oh. Okay, let me try. We even practiced this. Let me try again. Okay.
There you go. Yeah.
Okay. Okay, sounds good. So my talk is health equity and diabetes care for older adults, and we'll be talking specifically about culturally tailored approaches. This, 40, 45 minutes is definitely not enough time to do justice to these areas of health equity, diabetes care, and older adults. But my goal is that we just consider all of these things from the patient's perspective, and we'll be applying some tools and frameworks. Let's see. Did it advance for you? Okay, great.
Yes.
So I have no financial relationships or commercial interest to disclose. The Shape to Fit program is funded in part by the Archstone Foundation. I'd like to thank the following folks for their contributions: the Los Angeles Alliance of Community Health and Aging, and my partner, Dr. Phyllis Willis, social worker at Watts Labor Community Action Coalition, as well as some of our folks here in Department of Health Services in LA County. I'd really like to thank Senora Maria Aguilar, who is a Watts community member with newly diagnosed diabetes. So our objectives for today, spoiler alert, this talk does not focus on traditional medical management or pharmacotherapy, but I really hope that the talk can help inform providers of all different disciplines to provide culturally tailored care. So we're going to be working on sort of recognizing the key issues that are important to diabetes care for geriatric populations with a diverse background. And as a sort of case example, we'll be talking about those voices from South Los Angeles. We'll talk about adjusting the goal of the hemoglobin A1C based on individualized elements like risks and frailty. And we're going to dive into the geriatrics 5 M's and racial justice frameworks to do so. And finally, we'll employ intervention strategies with shared decision-making for diverse older adults. So designing collaborative care plans, understanding our patients' life course and cultural factors. All right. So this is a slide from back in February 2022 when we were doing our first sort of the beginning of our Shape to Fit program in Watts. And Senora Aguilar is the woman in the middle with the white hair and the glasses. And she actually shared her story live on Zoom and shared how when she was diagnosed with diabetes as an older adult, she was sort of given a bunch of prescriptions, but not a lot of education or resources to help her self-manage. And she talked about how difficult that was and how it really took several visits and several attempts on her part to be able to really feel comfortable checking her blood glucose, to feel comfortable taking the medications, and also knowing what foods to eat and what foods not to eat that were available in her own community. So we'll keep coming back to the importance of learning from and inviting the voices of our patients and community members during this talk, because it's crucially important that no matter where we are practicing, providers must learn how to provide culturally tailored care. We get a lot of algorithms. We'll actually be looking at some of them from, different societies and organizations about how, the care should be, but we actually need to tailor that care to fit the needs of our patients. This is a picture from the Los Angeles Community Academic Partnership for Research in Aging, more community voices that help inform how providers can best deliver that care. Some of the themes from the Shape to Fit participants, like Senora Aguilar, who participated in an evidence-based, based on the Stanford model of chronic care and adapted to their own needs in South Los Angeles. Some of the themes of focus groups that answered these questions: how do you self-manage? for our African American and Spanish language participants, they cited that self-management really included a focus on nutrition, on communication with their healthcare provider, cost, sort of trying to figure out what they could afford to purchase, and then exercise. Those were the same themes that came out in the interviews around where they struggle with managing their diabetes. So again, they struggle with managing their nutrition, the cost of medications, exercise, and just costs overall for managing their diabetes. And a lot of the older adults in Los Angeles County, and I'm sure across the nation, depending on their documentation status, if they're undocumented, might not be eligible for insurance. Fortunately, in California, we had the expansion of Medicaid or Medi-Cal to cover all adults 50 and older, regardless of immigration status, so that cost and medication costs is a bit ameliorated. But that is a big barrier that our Shape to Fit participants voiced. In terms of what are their supports, they do cite the provider, and so that's why we're here today, to learn how we can best support our patients. They also cite their family, community classes, their self, and the research that they might do on Dr. Google online. And then a really interesting question: what would you change about your care? These are the themes that came out, and the themes that kind of stood out over and over here are nutrition and communication. So we definitely will be talking about that today. In terms of the trends and leading causes of death, at least in Los Angeles County, and I'm not sure if this data is available in everyone's counties, I find it really interesting when you look at the data from 2008 to 2017, that up on the top right, you'll see that the coronary heart disease is still the #1 leading cause of death. But for the other causes of death for age-adjusted mortality, you can see that the ones that are sort of increasing is Alzheimer's disease, which is really starkly increasing over the years. And diabetes is also one of the ones that, you know, we'd like to say we've kind of flattened it or decreased it as a cause of death, but it's actually one of the few that are increasing. So I just bring this up because, as we know, diabetes is a risk factor for coronary heart disease, as well as Alzheimer's and stroke, and many of the other things on here. And so it's really important that we think about how to address this trend. So as I mentioned, a lot of the participants in our community-based group talk about the importance of nutrition. They also talk about some of the misconceptions and barriers that they experience when they talk about diabetes with their providers. And there's this sort of shame and blame game, that all rhymes, that we sometimes do, sometimes inadvertently, around sort of when we're doing some brief counseling in nutrition. So here you can see a graph that just shows consumption of at least one soda or one sugar sweetened drink per day for children and adults by race and ethnicity in Los Angeles County. And this is a little bit old, in 2011. Hopefully we're doing a little bit better now. But you can see that Latino and Black citizens are saying that they do drink significantly more sugary drinks than white or Asian American. But then if you take a look at the price indexes for selected foods and beverages, here you can see that the price of some of these things that they're saying that they're drinking or maybe eating, the prices are relatively low and stagnant. So carbonated drinks are very low cost. And if you look at things that we're telling our patients to purchase, like whole fruits and vegetables, those are the things that the price has gone up dramatically over time. So it's no wonder that for lower income communities that have a harder time affording food, that they will reach for those sugary drinks and foods because they are cheaper. So I know this is an echo. We are going to have a little bit of discussion around two patients. I'll introduce you to. So this is our first patient. She is a 68-year-old woman with type 2 diabetes. Her A1C is 9.7. She has obesity, osteoarthritis, depression, hyperlipidemia, hypertension. She has mild cognitive impairment, some diabetic retinal disease, and has had falls. Our next patient is a 72-year-old man with an A1C of 11. He is also living with CKD, BPH, coronary artery disease, atrial fibrillation on anticoagulation. He has HFrEF, hyperlipidemia, hypertension, and hard of hearing. And I'm sorry, I know there's a lot of different disciplines on this call. So he has chronic kidney disease, prostate disease, coronary artery disease, heart failure, just to say those instead of abbreviate them. So those are two patients. They are not my two patients because my patients don't typically pose for Getty images, but anyway. So here's a quiz for you all. You don't have to answer unless you like putting things in the chat. So which is greater? A, the seating capacity at our new SoFi Stadium, or B, the number of Angelenos over 65 years old with diabetes? So A or B. SoFi Stadium is really big. So the seating capacity at SoFi is up to 100,000 as expanded for the Super Bowl. And the number of Angelenos over 65 with diabetes is over 300,000. So when I, as a family medicine geriatrician, think about 3 SoFi stadiums filled with people 65 and older with diabetes, just for Los Angeles County, I have a little panic attack. It's a lot. So when we look at the overall prevalence by race and ethnicity, because I think it's really important to disaggregate this data, we see that LA County overall for older adults, it's about 1/4 of our population has diabetes. For our Latino population, it's over 1/3. Our Black population, it's almost 1/3. For our Asian American population, it's 1/3. But for our white population, it's dramatically less, 17%. So that brings me to define something very important. You saw the huge disparities. So we want those disparities to go away. We want the outcomes of our interventions to mean that there are no racial disparities or health inequities. So let's define what is racial justice. Racial justice is the systematic fair treatment of people of all races, resulting in equitable opportunities and outcomes for all. This goes beyond anti-racism. It's not just the absence of discrimination and inequities, but also the presence of deliberate systems and supports to achieve and sustain racial equity through proactive and preventative measures. So this is why that sometimes when we are taught and given algorithms or studies about how to care for older adults with diabetes, we need to go beyond the cookie cutter approach and actually tailor those interventions to the communities that we serve and the patient before us. The Los Angeles Alliance of Community Health and Aging has adopted a racial justice health equity framework for all of our programs and education. And these are the pillars of our framework. So there are 5 pillars. I'm not going to read all of it because we don't have time. But the first pillar is really working to break down silos, to share and learn together, to use data to tell the story, to do investment and accompaniment with our community partners and patients, and to really seek mission alignment so that we are better advocates for structural change. Okay, so let's geriatricize. This is a nod to the late visionary Alvin Ailey, a dancer, choreographer, and activist, also celebrating as we are in Pride Month and his contributions. Oh, and I forgot to mention, that's actually an Alvin Ailey fitness class at a senior center. So I'm going to go ahead and share with you the 5 M's. I don't know if this has all been covered in this eco series before, but we'll apply it to diabetes here. So the 5 M's That's 5, like a high 5 or 5 fingers. And I often ask our trainees to, come up with, what do you think those 5 M's are? And almost everyone starts off on the right foot with memory or medications. I'll go ahead and give them to you. So the 5 M's that we use as a framework for a lot of things in geriatrics, very helpful. One is multi-complexity. And that's really talking about the holistic community social situation that our patients live in. And typically as people age, the complexity actually increases, whether it's socioeconomic or linguistic, being able to care for themselves, having a caregiver. So they have complicated biopsychosocial needs. The other M's are mind, which includes memory or delirium, depression, dementia, mobility, which is very important. We just saw that picture of the Alvin Ailey exercise. So mobility is function, gait, balance, falls. Medications, polypharmacy, preventing polypharmacy and the prescribing cascade and deprescribing, and also paying attention to potentially inappropriate medications in older adults. And then my very favorite, what matters most. So that's the big M, the double M, and that's really making sure that we're aligning care with the individual's priorities. And this is where our discussion today around health equity really centers both in the structural and in the individual approach to diverse communities and patients. So as busy clinicians, I know we all love tools. This is a nice tool from American Geriatric Society about how to best manage diabetes in older adults. And I'm not going to read through this, it's very small, but you'll have access to my slides. I think it's important that we look at tools that are specific to older adults because, as you know, there's a lot of bias in the studies that we have available to us as primary care providers and as geriatricians, that the studies often exclude older people. They exclude people with comorbidities, and the studies often are not representative of marginalized communities. So I say that because we need to take all of these tools and studies with a grain of salt, because it might not have included the patients that we actually serve. But here's a nice tool, and there's a couple pages of it. And what I wanted to highlight is the goals of treatment for older adults. The hemoglobin A1C goals actually can be modified based on the person's overall health. So if they're deemed, overall healthy, robust, it's okay for their goal to be around 7. If they're more complex and have poorer health, you might liberalize that goal to up to 8. And if they're very complex in poor health, then really designing a care plan and a A1C goal that minimizes harm, the goal of treatment can be up to 9. So this is a nice handy tool, and you guys will have it available to you. Here's another view of that. And this actually includes, in addition to the A1C goal, and this is from the American Diabetes Association supplement from early last year. It also includes the preprandial glucose, bedtime glucose, blood pressure goals, and lipid goals. So this is handy. And I promised I wasn't going to go into all of the details of medications, and I'm not. I wanted to, it's hard not to, but I wanted to make sure to share with you also, there's a lot of tools in addition to the ones from the American Diabetes Association, American Geriatric Society. We've also developed on a free platform called 1 Degree, some clinical and social medicine tools to help you support your patients living in different communities. So 1 Degree is pictured here on the right. You can actually geomap where your patient lives with the different tools or community-based programs, such as adult day health centers and community centers, such as parks and recreation, transportation and food, by using 1 Degree and plugging in the patient's address or your clinic address and seeing which resources exist. We made it a little bit easier by creating a geriatrics community resource guide on 1 Degree. So you can find that under the collections. And in that, we have developed folders with resources for advanced care planning, caregiver support, dementia, elder abuse, on and on and on. And so this is a really nice way to, if you haven't already seen it, to be able to augment the care that you're providing within the four walls of your clinical space into the community where patients actually live. Okay, so let's go back to our patients. So I think, you know, when we see this kind of medicalese, you know, where we see these abbreviations and an age and kind of a stock photo, we're just kind of thinking in the old model. So I want to apply some of what we've talked about back to our patients. So we'd like to have a new mindset. What's the patient's perspective? So when we talk to Senora here, you know, how is she feeling about her overall health and functional status? How is she feeling about the care that she's receiving? How would she answer those questions that we asked the Shape to Fit participants about what they know, where they struggle, what they wish their care team had done differently for them? And how about our gentleman on the right? So when we really talk to our patients, we find out that Senora A is a Spanish-speaking undocumented immigrant. She shares that she actually has difficulty reading pill bottles and she's really scared to inject insulin. She heard that when you inject insulin, you end up needing dialysis, and that's a common myth or misconception. She also gets all of her pill bottles and medications printed in English, and she really has no idea what they're for. She also really misses home, and she got lost trying to return to Mexico. If you recall, she has some cognitive impairment, which is progressing, and she often gets lost and has trouble using the buses now. When you talk a little bit more and listen to Mr. B, you learn that he is the IHSS or in-home support services caregiver for his wife who has dementia. He's frustrated because he has to get up frequently at night to urinate. And he also has had some falls when he's getting up in the middle of the night every 1 or 2 hours because of his prostate disease and because of his poorly controlled diabetes. But he really wants to stay well enough to care for his wife at home. So how would this information change your office-based assessment? And what tools might you use for each patient to really help them achieve their own goals and to achieve health equity? So we're going to apply the geriatrics 5 M's, remembering that multi-complexity or the biopsychosocial situation of the patients, whether that's housing and food insecurity, whether that's legal and immigration status, whether that's poverty, that is really going to dictate all the rest of the care, no matter how many medications or how perfect our algorithm is. The multi-complexity before us is what's going to dictate the care. And I recognize that this takes time, but it's time well spent, because if we don't spend this time, then we're really missing the opportunity to partner with our patient to better self-manage. So we know that for both of our patients, in terms of mind, that Senora A has cognitive impairment. So we're going to need to adjust our goals and our approach. We're probably going to have to enlist the support of a caregiver or a family member to help. We know that for Mr. B, he is having falls, and so his mobility is really an issue to address in our addressing his diabetes care. If he has a catastrophic fall and a hip fracture or some other injury, he's not going to be able to stay home to take care of his wife. In terms of medications, and we're going to look at that on the next slide, you know, we want to tailor the medications that we are prescribing, both for diabetes, but also for all of their other comorbidities. You saw that both of these patients in our cases have a long list of other chronic medical conditions, each of which has its own guidelines for all the medications that they should be on and all of the targets and goals that they should be meeting. And so what I'd really like to emphasize here is that we've tried to elicit in our patients what matters most. for Senora A, she really misses her community in Mexico and her ability to get around. She's trying to, use the bus to try to get around her neighborhood, and she's suffering cognitive impairment, so she's getting lost. So how can we tailor her care so that we can help her achieve what matters the most to her? Same for Mr. B. We know that his primary goal is to stay healthy enough to take care of his wife at home. Their income depends on him being an IHSS caregiver. So we need to prevent falls. We need to keep him mobile and functional so he's able to do that. When we look at medications, and full disclosure, this is an actual list of my patient, and I'm a geriatrician giving this talk, my patient's list. And can you see on the right, there's a scroll bar and it's like barely past halfway. There's a lot of medications, okay? Now, I just saw this patient and I did discontinue and change some of the medications that my patient is on, but this is a whole lot to handle. And you can see that there's a combination of injections and topicals and orals and multiple times a day. And it is polypharmacy. So this is not unusual at all. In fact, this is usual for my patients, that they're on way more than 5 medications. I try my best to minimize the medications and to simplify the regimen. But for the patient for whom this medication list belongs, I had been struggling with her diabetes. We've been trying to get her A1C at least under 9. And this patient actually has not improved until just recently. I saw her on Monday. Her A1C is finally 8.7. And it wasn't because of me. It was because she started to attend group medical visits with community members in the park that were led and facilitated by our community health worker, our promotora. And she got engaged in self-management and checking her sugars. She also has been working with our diabetes nurse educator, who's been helping titrate her insulin, and had completely, recommended changes to the regimen I had her on. And now she's doing so much better. So I really took that as a lesson from this patient. And I think I want to take this opportunity to just talk about health literacy as it pertains to our patients' care for diabetes. So health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services to make informed health decisions. So in terms of my patients' health literacy and the patients that we just shared, they need to have time. They might need to hear it from different members of the care team, not just from the physician or the clinician. They might have to hear it from members of the community in sort of a facilitated either group visit or something like Shape to Fit, where they're hearing it as a curriculum over time in order to really process and understand the health information about diabetes management so that they can make informed health decisions. We know that there's, oral and written and numerical literacy involved, and that a lot of our patients, especially from underserved backgrounds, have not gotten some of the basic education to be able to understand, some of the written and numerical or quantitative information they need to manage diabetes. And I just want to share this picture, right? Because I know that oftentimes we imagine or we think that patients, just will get a syringe and a vial or a quick pen and all of their problems will be solved. But these things are actually really complicated to assemble and to use correctly. Patients are understandably pretty scared about having to inject these medications and dose the medications, especially when they have issues with their own self-management capacity. So if they have vision impairment, one of our patients in our case has diabetic peripheral retinal disease, so is not going to have, has diabetic retinal disease, so is not going to have the best vision. Osteoarthritis and just being able to manipulate these, injections can be really tricky, putting together the insulin pen with the needles. And then you have cognition, and I'm not going to talk about diabetes and dementia. I think that's a very important topic, and one that we will be hopefully diving into in a future session. But when people have limited cognitive ability based on baseline low health literacy, but also with neurodegenerative changes, then diabetes management becomes even more difficult. So the first thing that we want to do for our patients is try to simplify any complex insulin therapy. Insulin is great and is indicated in a lot of our patients, but for some, it might not be the best option. You might be better off taking away the insulin and sticking with an all oral regimen. But for those of whom that you really want to partner with to self-manage with insulin, here's a nice guide, again, from the American Diabetes Association that shows some different steps you can take to simplifying their insulin therapy, both the basal insulin and the prandial insulin, or if they're on a pre-mixed solution. So the tips that I wanted to highlight is to not use rapid and short-acting insulin at bedtime, because that often results in hypoglycemic events at night. And as we saw, a lot of our patients are getting up in the night to use the restroom, and so that can result in falls. And then when adjusting the prandial or mealtime insulin, to really use a simplified scale, because a lot of the time our sliding scale instructions are pretty complicated with carb counting. And so just to set basic goals, like if their pre-meal glucose is greater than 250, to give 2 units. If it's greater than 350, to give 4 units, and so on. Just a very simple sliding scale. And then stop the sliding scale when it's not needed daily. Having to take prandial insulin and having to do that adjustment with every single meal and checking sugar so often is often a barrier for our patients. Why do we do all of this? This is all very important. I think that there's a tension, I feel, as a geriatrician and family doctor, wanting to really help provide excellent diabetes care and excellent A1C control, especially because, you know, the health plans and everybody is monitoring that. However, my ultimate goal is to help patients prevent the long-term effects of diabetes, which they often don't recognize as effects or long-term outcomes of diabetes. And so really connecting the dots for our patients that, you know, we want to create a treatment plan, nutrition, exercise, all of the things to be able to help them self-manage their diabetes so that we can prevent these long-term outcomes. Stroke, vision loss, heart failure, heart attacks, kidney failure, sexual dysfunction. These are all outcomes that patients don't necessarily see or feel as related to their diabetes. What about peripheral vascular disease? So when I look at the communities that I serve in Los Angeles County, the amputation rates are 10 times higher for low-income communities in Los Angeles than they are for high-income communities. So back to our health equity theme. If you look on the left, the lower extremity amputations, which the darker is the higher number of amputations, you can see basically a straight line down the middle of LA County. And that basically is, you know, the 110 corridor ending in the Port of Los Angeles, where a lot of our low-income communities who are exposed to toxic environmental hazards, as well as food deserts and poor access to healthcare. And you know, the map on the right-hand side shows people living at less than 200% of the federal poverty level. So the maps look very, very similar, and I don't think that's a surprise to any of us in healthcare. But this is why, if we can prevent these amputations, heart attacks, blindness, by better partnering with our communities to care for their diabetes, we have done our work. So here are some takeaways. We had as our goals to recognize key issues that are important to diabetes care for a geriatric population with a diverse background. And so we really identified some of the issues that they voice, at least in our South Los Angeles community. And I encourage you to ask your patients and your populations, what are their key issues? Our patients identified nutrition, health literacy, language, and addressing racism and bias. Not blaming patients or their cultural foods or their level of income and ability to do certain things that we prescribe, but really partnering with them. We also had as one of our goals to adjust the A1C based on individualized elements like frailty for older adults. And so here what we did was we applied the 5 M's framework instead of just a simplified cookie cutter approach to an A1C goal less than 7, really taking into account the multi-complexity of the patient, the state of their mind or cognition, all of the other medications that they're taking, their mobility, and most importantly, what matters most to them. And then to employ intervention strategies in my setting using our expected practice, but also using things like the American Diabetes Association and other guidelines, but we want to do it in a collaborative way. So looking at the real life examples of our patients, whether that's that they are a caregiver, whether that's they're living with social isolation and they do not have caregivers, and really exploring their own perspective and sharing our recommendations. So as I wrap up, I want to ask you all, this is a whirlwind tour. What will you do differently? I really hope that you gained a little bit of knowledge using these frameworks, the 5 M's framework and the racial justice framework to approach your diverse patients. And I hope that we can all work together to promote health equity by working with our teams, our promotoras, community health workers, our social workers, physical therapists, occupational therapists, nutritionists. The list goes on and on. I know that there's somebody here from Meals on Wheels. Shout out to you. This is all part of the team of how we can approach our patients differently outside of the traditional medical model. This picture here, I just want to share is the gentleman in the blue puffy coat is one of my patients that came to me after being released from prison. He spent over 30 years in prison and came out of prison with COVID, entered into the care of us here at Lomita Harbor UCLA Family Medicine, and standing next to him is our community health worker who has known him actually in prison and now outside of prison in our clinic. And so these types of therapeutic relationships are really important for improving diabetes and everything else. So to end, I just want to thank you all for your attention and participation. I'll definitely take a look at the chat and be happy to answer any questions. My slides will be available and all of the references are within the slide set. Thank you very much.
Thank you so much, Dr. Shikadins. That was a wonderful presentation. Does anybody have any questions for Dr. Shikadins? You can either unmute